I hope everyone had a really nice lunch. I'm going off script for a minute, but I know we touched on it this morning. I would really like to thank again all of our sponsors. You know, at most medical meetings, you have a high registration, and that registration covers like all your food and the activities and everything else. And because of our sponsors here, we are able to support that for everyone in the room, which of course includes many of our families. And so it's a really special thing. Marissa was extremely dedicated to this. And so thank you again. Round of applause. And now I get to introduce our keynote, and it's my absolute pleasure to introduce Dr. Chantada, who really needs no introduction. He's a leading figure in pediatric oncology and a dedicated advocate for retinoblastoma care and research. He currently serves as the director of the outreach program at the Pediatric Cancer Center in Barcelona and as the scientific director of pediatric hematology oncology at the hospital Perez, I hope I'm saying that right, in Montevideo. He has an impressive background, and he's also just an awesome person. He obtained his medical degree from the University of Buenos Aires and did extensive training with a focus, of course, on retinoblastoma, and he has contributed significantly to advancing treatment strategies for retinoblastoma globally. His research encompasses innovative therapies, including a new viral vector-based therapy for recurrent retinoblastoma, molecular mechanisms of tumor dissemination, and he focuses on improving outcomes for all children affected by retinoblastoma anywhere on the planet. Dr. Chantada's leadership roles include serving as current president of SIOP, and so we're so lucky that he was able to take some time to come out of his extremely busy schedule, which includes like 5 lectures right now at the same time, 3 dinners tonight. And you know, we're sitting here like now we feel surrounded by people who think and talk retinoblastoma, but to have a retinoblastoma expert be the leader of SIOP is not only so rare, but so special for all of us in the community and for doctors and scientists. And he's been pivotal in identifying RB as one of the World Health Organization's index cancers, with a goal of eliminating the number of children worldwide who die from this disease by more than 60%. When he is not doing all of that, he has 188 publications, a robust H-index. His work has made a profound impact on the field. And when I was a slightly younger version of myself in ocular oncology, Dr. Chantada answers emails. He is so kind and supportive to everyone in the field. He's open about clinical care and research in a way that not everyone in this field is. And my mentor, Dr. Murphy, always said he was a friend. And I'm so glad to now call you a friend as well. So please, we're so delighted to have you here.
Well, I mean, I could go on and on. Thank you. Well, I'm really touched. Thank you for this nice introduction, Jessie. First of all, thank you for the invitation. And most importantly, like now I'm talking like a SIOP president, thanks for doing this meeting attached to SIOP. That means really a lot for SIOP. Yesterday we had our strategic meeting for the strategy for the next 5 years, and we said these things, like having meetings like this one, should happen for other tumors as well, like renal tumors, CNS tumors, etc. So hopefully this will be an example of what SIOP will do for other tumors, and retinoblastoma was the first one. So again, what a pleasure for me to be here. Let me, first, I don't know the answer to the question if we can cure retinoblastoma worldwide. Let me try to discuss with you how we can certainly achieve that really ambitious goal. You all know that there is a survival gap in retinoblastoma. So depending on where the child is born or where the child lives, the chances of survival are different. And when we read the textbooks that are written in high-income countries, for the first thing you read is that retinoblastoma is a highly curable malignancy. But if you see the curves, and that is really probably optimistic because I tried to put the 2030, which the WHO put like a deadline to achieve the 60% cure worldwide on retinoblastoma and 5 other tumors. But we were lucky that retinoblastoma was chosen among this number of tumors. But if you live in a high-income country, you would say, what, we already have 95, 97% survival rate, and are you going to go only for 60? But if you really know that most of the children live in low-income countries where many of them are not even diagnosed with retinoblastoma, and there are many settings where I listen from my colleagues that I haven't seen a child cured of retinoblastoma. That is really what the situation is in the world. And there are a few factors that we will try to come up with that make this different in survival. But it is really not because the disease is different. It is probably not the molecular difference. It is mostly related to socioeconomic factors. Like 14, 15 years ago, we did a study that was a systematic review of papers, even published in the great literature, where we found that these major indicators, socioeconomic indicators, like, for example, the Human Development Index, the maternal mortality rate, were predictors of extraocular disease and survival in retinoblastoma depending on the settings. So at that time, there was a study that was very interesting about leukemia, where they correlated the same factors and saw that one of the factors that was very well correlated with the survival of ALL, with acute lymphoblastic leukemia, was the amount of money that the government invested in public health. That was not a correlation in retinoblastoma. And why? Because retinoblastoma can be cured only with enucleation. You don't need a bone marrow transplant, you don't need a high-dose chemotherapy, etc. So the highest correlation was with the Human Development Index of the country, which is a very composite index that shows mostly the health system description of those countries. Later, in much elegant way than we did and more scientifically sound, the group from Didi Fabian did a wonderful study that was a prospective collection of thousands of cases all over the world with little or lower representation on low-income countries, and he showed also that there is this survival gap, but he was able to put the numbers on the survival gap. But again, these are probably too optimistic. You say here in the bottom that the overall survival of children in low-income countries, according to his data, is around 50%, which again, I think it is probably over-optimistic. It is around maybe 20 to 30% in most of the cases. And it's not only the survival is different, the cause of death is different in these settings. So while those who practice in high-income countries very rarely see a child dying of extraocular disease, very rarely see a child dying of the toxicity of the treatment, and most of the children that die, don't die of retinoblastoma, but the persons that die with retinoblastoma, it is because of the secondary malignancies that could be influenced by the genomic background, but also because of the treatment received like decades ago. When you see the causes of death in upper middle-income countries or middle-income countries, you see that extraocular relapse is the most common, extraocular relapse or extraocular disease is the most common cause of death. Also, interestingly, the toxicity-related mortality comes because disease is more advanced, they need more intensive treatment, supportive care is less, there are family socioeconomic issues that create this mortality because of the treatment. You'll never see that in high-income countries. And it starts to appear with one very critical factor, which is abandonment of treatment. Abandonment of or refusal of treatment families don't accept the proposed treatment, which is most of the time enucleation. So children that could be cured are not cured because of the family that does not accept. And in low-income countries, abandonment is even a higher problem, especially when the disease is intraocular, when the disease is still curable, but also when the disease is extraocular, when we might say, well, the child is going to die anyhow, but palliative care is usually not offered to these children, and retinoblastoma can be really a very painful and problematic disease when palliative care is not provided to these children. So they virtually don't see secondary malignancies because only 10% of the children will survive, and usually are the ones that have unilateral disease. So to make the presentation simple, there are two major problems in the world for curing retinoblastoma. One is the disease presents with more advanced features, and second is the poor treatment compliance. So how can we, as the healthcare community, operate into these factors to cure retinoblastoma? Because there is not going to be, at least in the foreseeable future, a new drug that magically cures extraocular disease. It's not that we can take Jesse or great ophthalmologists to a low-income setting and retinoblastoma will be cured because they are great ophthalmologists. It is because patients live where they live and they have to live in their socioeconomic situation. So it is much more difficult than that. So I will try to go over a few scenarios of how can we really reach the end and cure retinoblastoma all over the world. We talk about a lot of screening. By instinct, we say, okay, retinoblastoma is a disease that you can see in the child. It's not like neuroblastoma, which is in the abdomen, that you can't figure out if the child has a neuroblastoma or a renal tumor or something else. Retinoblastoma is relatively easy. You can see it's in the face, looking at the children's face. So many of us try to pursue screening strategies. But screening is a very complicated word. I learned that from many failures to present grants, to try to convince the decision makers that we have to pursue a screening strategy for retinoblastoma. So screening means that you are going to target the population of people that don't know they are sick. So when we talk about screening, it's that we talk about going to the population, looking at the children that their mothers don't realize that these children have anything in the eye. So they didn't have the idea that what the children have need to be seen by an ophthalmologist. And this is also an overestimation, because I just put in this very simple slide, these circles which are blue are the persons that don't have retinoblastoma, and maybe the one that is in yellow has retinoblastoma, so it will be like finding a needle in a haystack. And this is one big limitation of retinoblastoma. Why? Because here I Google an image of a stadium where 17,000 people are there, and one of them would have retinoblastoma, because the incidence of retinoblastoma is around 1 in 17,000 children. So imagine trying to pick one of these persons. One of them would be one in 17,000 would have retinoblastoma. So it is really a rare disease. So it is really complicated to go for screening the general population with a rare disease. And the adult oncologists already did that. There are a few tumors in adult oncology that are amenable to screening. So here is a comprehensive list of which are the tumors, of how are the tumors described that we could do effective screening. And it is a very busy slide, but first the disease is suitable for screening. We can say yes, retinoblastoma is suitable for screening because you can see it in the eye. We don't talk about prevalence, but it could be screened. A suitable screening test exists. That we cannot say that. We are going to discuss a little bit later, but there is no mammography, there is not pap smear. We don't have a validated test to screen healthy people for retinoblastoma. There is an accessible and affordable treatment. There is, but we have the abandonment, we have the limitations of healthcare. There is a high quality evidence, preferably in randomized studies, proving that screening improves survival. So screening for low and middle income countries need to improve survival. We don't have that. So if we really want to go for screening, the first thing we should do is to try to put science behind and do it a randomized study like mammography, like cervical cancer. Otherwise, we will not be able to convince the decision maker. So there is an evidence that the potential benefit from the screening program outweighs physical and potential psychological harms. We don't know, especially in settings where the anesthesia is not safe. You have to anesthetize probably 17,000 patients to pick one if you really want to do retinoblastoma screening. So it is a very complicated decision maker. Not talk about the last ones because they are even more difficult because they talk about cost effectiveness, for example, which is again something that is, because it is not a prevalent tumor like breast cancer or cervical cancer, we will never convince the decision makers that screening on retinoblastoma is a good idea. But we have the way we have to counteract this statement is that tumors in children have a different biology. And that is a good example on retinoblastoma because it's a narrow age range. You don't, with breast cancer, you have to screen a woman from the 40s to the 70s. In retinoblastoma, you may have to screen from 6 months to 2 years. So, and there is no, it is not a disease that goes very slowly, so you will be able to pick it. So we can still make some discussions, but I think that we are not ready yet to screen the general population in low-income countries. And when we talk about, we have to have a screening test, a validated screening test. What do we have? Besides the great models from Ashwin, which are really great, we have the red eye reflex that has been tested for other conditions, ocular conditions. And as you know, there are many discussions. It is low sensitive test, relatively high specificity, but very low sensitivity. It is not tested enough in colored people, so we don't know exactly how it works, and it's mostly done in neonates. There are less evidence in older children, at least what I could find. This is what I have even a TED Talk about this, and that was a frustration because I couldn't, even with the TED Talk, I couldn't convince the decision makers to support the grant to develop these phone applications where you could actually take a photograph. Now with artificial intelligence could tell you if that child, probably if that eye has retinoblastoma. We have here in the audience people that are really working in the field. I think it is very promising. It needs validation. You still need a cell phone. You still need to screen the 17,000 people to get some results. And you still need the compliance of the test, because if the family don't comply, when they know that they have a child with cancer, probably it will be difficult to comply for a screening test. Like they don't comply for mammography, they don't comply for pap smear. So we have to have that in mind. And let's imagine a scenario. What if we really convince someone? What if the decision makers at that time, I could have convinced them? So which is the best test we have to discuss? Digital photo versus red eye. Which is the age? We should arrange for an age. We can go when the children are younger, maybe it's easier. They go to the pediatrician, they look for medical care, but maybe we can miss some children that will present later. Probably the age of 1 year when they receive the viral vaccination is a good time. We have to do a randomized study. We have to screen one population and not screen other population. Maybe we can screen Monday, Tuesdays, and Wednesday, and not screen the Thursdays and Friday, and then compare the population screened and non-screened patients. Otherwise, we will not be able to prove it works. And the outcome, the endpoint, is to reduce retinoblastoma mortality. But in order to do that, we have to know how much it is. We need to have national data. We have to have registry, at least retrospective data, national data, because otherwise we would not be able to prove any advance. So we need this baseline, and we also need to ensure that if we pick a child with retinoblastoma, can be effectively seen, treated in a health institution. So we need a lot more than a wide reflex in a cell phone. And again, we need, I will say this very many times, we need an effective treatment for abandonment, because again, if the families still abandon when they know they have a child with cancer, if they say, well, your child might have cancer, you have to take the child to the doctor to see if probably this is a false positive or not, probably it is not going to happen. And that I learned from the ophthalmologist, that perhaps you don't pick retinoblastoma, but you pick other ocular diseases, which are also important, and especially cataracts or others. And that's the WHO approach, because WHO says, okay, we cannot recommend screening for a rare tumor, but we can recommend screening of ocular examination for ocular conditions in general. And then is the way we put retinoblastoma in the table. So suppose in a simulated country, children under 5 population of 10 million, probably there are many countries like that. The under 5 mortality in those countries, suppose it's 30 over 1,000 patients, which is sadly the reality in the countries where you have mortality on retinoblastoma. So there are 30,000 children dying of other causes, retinoblastoma included. So most of them are infectious diseases, diarrhea, lung problems, etc. So you would expect 170 retinoblastoma if you screen and you detect all the patients. You would probably estimate that you would have 120 children dying every year on retinoblastoma. Which are the challenges if you really try to go for early diagnosis in these children? The low prevalence, again, only 117 cases will be picked in 10 million. You saw, imagine the picture I showed with the stadium, imagine 10 million, not 17,000. Usually, if you, even if you have a very sensitive and specific test, you need to confirm the diagnosis, and that needs anesthesia. And in those settings, there are no anesthesiologists, or very few are pediatric anesthesiologists. And the mortality rate of an anesthesia is not negligible. We are going to talk about later. You need an ophthalmologist. Maybe there are countries with 2 or 3 ophthalmologists. They are very busy seeing very sick children. We are probably going to see children that have nothing. Again, compliance, the mortality, under 5 mortality is very high. If you take a mother out with a child that probably has nothing and leaves the other 5 children they have, when they come back, some of them could find that one had diarrhea, pneumonia, etc., and died, and will not affect our under 5 mortality rate. And again, a few words about anesthesia. The only data I could find in pediatric anesthesia in low and middle income countries were from Pakistan. The mortality is 0.2 every 10,000 anesthesias. So it is low, but if you screen, we are talking about screening potentially healthy children. So 1 child every 100,000 will die of the anesthesia. Most of them died because they had also congenital heart disease, which is going to probably be underdiagnosed as well in those settings. So you will put in anesthesia a child that you don't know if he has a child with a congenital heart disease. So it's a really very, very difficult decision to go to the general population and try to do a screening test. But the awareness campaigns and making the disease, making the general population more aware of the tumor, our tumor, is really important anyhow. Even if we cannot prove it by randomized studies, if it is difficult for us to make a scientific statement that it really makes a difference, it really can make a difference in the other factors, which are when we took the child with the yellow circle that has the retinoblastoma, and that child is already in the medical system, it is incredibly late that the medical system make the diagnosis. So you see here that in Brazil, it took 6 months when the child was entering the hospital until the diagnosis of retinoblastoma was made. It took 6 months. So that is really unacceptable, and that is really actionable, because we are not fishing in the ocean. The child has already a diagnosis of retinoblastoma, or a probable diagnosis of retinoblastoma. So we can really reduce the time to diagnosis. We can educate the pediatricians. That was done mostly by groups in Mexico. Carlos Leal was one of the first. The work that Helen has done creating a referral center in Kenya a few years ago was really a way to go. What we did in Argentina when I worked there, when a patient arrived with a suspected retinoblastoma, had to be seen the next day. If the child needed a nucleation, that should happen the same week. So that was like an urgency for the hospital. You had to have unrestricted access to housing, to multidisciplinary team like Cancer Africa is doing right now. But again, sometimes it's also late when you make the diagnosis and start the treatment. So you have to speed up the diagnosis time. We were discussing with Ashwin recently. Sometimes a child is seen with intraocular retinoblastoma. The doctors ask for a CT scan because they don't have MRI. The family comes back 3 months later because they had to pay the MRI. They didn't find the time. The other child got sick. That shouldn't happen, because this is really actionable for us. We have to cure the curable, start from there. So the operating room time needs to be like an urgency. You have to nucleate the child. It's not like an elective procedure. It's an urgency. It's like an obstructed bowel for the hospital, because you can cure a child with cancer. You have to omit unnecessary, maybe unnecessary is a strong word, but if your CT scan is going to take 3 months, don't do the CT scan. Just try to save the eye, try to save the child, sorry. You have to have access to drugs. That is how St. Jude is working now with the platform, so the drugs can be for free for all the children with cancer in the countries that are more vulnerable. We have to be flexible. Sometimes we have everything, but the family says, no way, I won't accept that the child will be enucleated. So we have to be flexible, we have to take time, we have to go with multidisciplinary teams. Sometimes we need to give it even chemotherapy to buy time in order to convince the family that sometimes the child has to be enucleated. And also you have to give good treatments. This was the experience when I worked in Argentina for over 30 years. We went up from 85% overall survival in retinoblastoma to the current one, which is 97%. And this is because we really target the treatments for the disease we were seeing. The first time we were using North American protocols, which were very light for what we have. Because we have more advanced tumors, we needed more intensive chemotherapy to cure the children. So the treatment that you give also matters, because you can cure the children with better treatments. This is the Central American experience when they had abandonment from 16%. This is Journal of Clinical Oncology. What they did was just to give preoperative chemo to the ones that didn't accept. Yes, the results are still lower than the ones that accept, but the abandonment rate went 16 to 4%. And these children now are cured. This is the impact of the Center of Excellence. This is shown the Argentinian results. So you see here that the results in the referral center are better because we have experience. It's not because we are more clever. We see 40 patients a year. And this is what SIOP and St. Jude is doing with the ARIA guideline. Here, the head behind ARIA, Michael Sullivan. We are really putting more science behind adaptive treatment. We are doing more effectively what was originally done by SIOP with adaptive therapies, and now probably the guideline on unilateral retinoblastoma is going to come up very, very soon. And this is also what the AMCC is doing in Africa, providing support for the better treatment. They buy equipment, they train the ophthalmologists so they can make a difference there. So treatment abandonment, again, I will repeat it many times. First described in Indonesia, you have to have really courage to describe that 20, 30 years ago, because everybody wants the results to be like in the high-income countries, but they say no, and this is what's happening is that the family don't accept. There are heavy influence of socioeconomical issues. There are geographical variations. Families refuse treatment for different reasons around the world, so it's not, you don't have a one-size-fits-all solution for them. And incredibly, in some areas, it's more prevalent in girls. Unfortunately, women are denied the right to be cured in some cultures, which is really unacceptable. And we have to differentiate the children that abandonment when they have a curable tumor, when they have extraocular disease, which is not curable. So if you're waiting for an answer, if we can cure the children with retinoblastoma worldwide, all of this will cure retinoblastoma worldwide. And that is what the WHO, mostly supported by St. Jude, also supported by SIOP, are doing. We see that this is a very complex issue, that if we don't tackle everything from the left to the right, we are not going to cure retinoblastoma. So thank you very much again. It's been a pleasure for me to be here with you, and of course, I'm happy to take questions.
I could have our next session panelists come on up to the stage. May I get another round of applause for Guillermo? Thank you so much, Guillermo. When we found out that his PSYOP schedule would allow him to be here with us today, it was quite exciting. I am personally really looking forward to our next session, a global conversation. This is a new format for us here at One RB World, having an open dialogue with some of the leaders in the RB field as opposed to actual presentations, engaging in a really important conversation about the World Health Organization's 2030 initiative that you heard Guillermo speak about. So I really hope that you enjoy this next session. And it's also my pleasure to introduce our moderator. Pamela Paul is an opinion columnist for the New York Times, and she is also the former book editor of the New York Times. Last fall, she wrote an opinion piece that was featured on the cover of the Sunday opinion section called "It Takes a Lifetime to Survive Childhood Cancer." And I think everyone in this room knows that that is really the truth. You'll be hearing from her tomorrow, as she will also be delivering our keynote address tomorrow. So, ladies and gentlemen, please welcome Pamela Paul.
Thank you so much. Is this on? Thank you, Marissa. And what she didn't mention is that she was on the cover of the Sunday New York Times opinion. So, cover girl, Marissa Gonzalez, thank you. So just quickly to reintroduce everyone, we have Jessie Berry, I think everyone already knows, a director of Ocular, Oncology, and Retinoblastoma Program at the Children's Hospital of Los Angeles, scientific program co-chair of One Retinoblastoma World. Guillermo, I'm not going in order here. Guillermo Chantada, who we just heard from, of course, president of the International Society of Pediatric Oncology, the head of the outreach program at the Pediatric Cancer Center in Barcelona. God, you have many, many credentials. Shall I go through them all? The Hospital of Sant Joan de Dieu, scientific and academic director, Fundación Perez, Scremini, Montevideo, Uruguay.
That's good.
Lots of pronunciation challenges here. Michael Sullivan, pediatric oncologist at Royal Children's Hospital in Melbourne, Australia, the co-director of the International Society of Pediatric Oncology, SIOP, and St. Jude's Global Adapted Resource and Implementation Application, ARIA, okay. And the past president of SIOP Oceania. And then Luke Thomas, the Chief Executive Officer of World Child Cancer, London, England. The succinct one, thank you, very British. What I bring to this subject is neither experience nor expertise, but as a journalist, curiosity. So I'm gonna ask some very, very basic questions. And actually, I just want to start off, Guillermo, building off what you said, I want to talk about the World Health Organization's designated retinoblastoma cure rate of 60% by 2030. I'm curious, given all of the challenges that you just went through, how and why did it get named as one of these 5 index cancers? And what are the other 4? And sort of what were the conditions to get that designation?
Wow, that's a great question. First, we were lucky that retinoblastoma was picked up on one among the 6. The reason why retinoblastoma was chosen is because of the last slide, because it will need the whole healthcare system to improve the diagnosis. The other tumors that were chosen were Wynn's tumor, which is a renal tumor, which also has a high cure rate. And the reason why it was chosen is because it is mostly influenced by the surgery. So if you have a good surgery, the chances of cure are hopefully going to be good. Then acute lymphoblastic leukemia was the other one. And that is mostly because it's the number 1, it's the most common. If we want to make a real change in the number of children cured, we have to target the most common one. So small changes in ALL, we make big changes in the rest of the tumors. Then it's Hodgkin's lymphoma, which yesterday the program that Michael is leading released the first adapted treatment guideline for all over the world for trying to reach the 60%. It is also because it's a highly curable tumor and chemosensitive, and it will also include adolescents. So we can also target adolescents if we target Hodgkin's lymphoma. And then Burkitt's lymphoma, who is also a tumor that is curable, and it affects mostly low-income countries. So this is the list. And low-grade glioma, it's a tumor on the central nervous system that is it's one of the few tumors on the central nervous system that doesn't need a big and difficult treatment to be cured. Yeah.
Thank you. One of the other sort of obvious questions that arose for me during your presentation, and you can all address this as you wish, but the focus on screening, given all of the hurdles that you would have to sort of get over, especially in low-income countries, and given the fact that, at least from as I understood it, reporting on retinoblastoma, that this is the one rare cancer that you don't need to biopsy, that generally it's the parents who see it. Is the ultimate goal really that kind of screening test and that kind of universal screening, or is it awareness and education both among parents, but I would think especially among pediatricians or the pediatric ophthalmologists, the first people who see a child in the medical sense, to educate them to know what to look for?
Yeah, that's a great question. It's I like to hear also Jesse,
Yeah.
because most of the cases are seen also by an ophthalmologist. So I think Jesse's opinion will be really important for that question. Jesse, would you like to comment?
Yeah, I think I loved the discussion of screening and how hard it is. Even detecting leukocoria is quite hard. And so, of course, at least in the United States and many other places, children do see pediatricians, and pediatricians do know to look for it. They may or may not do that, given all of the other more common and also sometimes life-threatening diseases that they have to very, very quickly screen for in these children. But even when you turn the lights off and try to look into a child's eyes, they might be squirming, they might not be very good at it, the pupils don't dilate, it's hard. And so then you say, well, okay, we know how to do this. Put drops in the kids' eyes, right? Just dilate their eyes. How hard is it? Well, the complication rate from drops, even though it's extremely low, is still higher than the rate of retinoblastoma detection. So it's hard to find a needle in a haystack. Pediatric ophthalmologists, I would say, not universally, but by and large, pediatric ophthalmologists would detect this, an ophthalmologist would detect this, but children are not routinely seeing ophthalmologists, optometrists, or any eye care professionals. And aside from the bilateral cases where the children do not have good vision, the unilateral kids see just fine.
Right.
Right? They don't have any issues. Their parents will say, they see fine. I put a tiny tic tac down. They pick it up because their other eye's fine.
I mean, one of the things that struck me as a hurdle, just as a parent and having one child who ultimately did need glasses as soon as he, someone thought to test him, which I think only happened at age 3. And this is again in a city with 1 million doctors in New York and a high-income country, that I then realized, wow, he didn't even have his eyes tested until he was 3. He was not seeing that entire time. So I'm curious, like, how difficult is it on a global basis? You could speak obviously to the United States, to get doctors to refer patients to pediatric ophthalmologists, get them to have an eye exam.
I might come in with it, if that's okay. Just so I'm not going to compete with this extremely eminent, as you may have noticed from the brevity of my introduction, I'm not a doctor. So I'm not going to compete on the medical front, but World Child Cancer, we do work in a lot of countries around the world where this is a big challenge. And I think that, so I used to, prior to working with World Child Cancer, I used to work with an organization called Sight Savers, which is an eye health organization, as the name suggests. And one of the things that they did to try to overcome some of these challenges of getting to these very rural communities and the high numbers of people you need to screen to sort of refer on for treatment was to develop something called the Rapid Assessment of Avoidable Blindness. And this basically used existing systems and existing community members who sort of played, so either, for example, using vaccine sort of checks, using that to us, and during vaccine checks, look in the eyes. Check the eyes, just do that. It's a really simple, basic check, like you're saying. That was one thing. And then the second thing they did was to train community volunteers, people who were already trusted as medical or semi-medical people. And these might be people who are, for example, faith healers or traditional healers. Actually give them very, very simple, basic training to look in somebody's eye and say, what do you look? When you see this, instead of trying to go through traditional routes, refer. So you're actually working with the community leaders who are already seeing the children, because I think in many countries, 85% of people who get cancer, some sort of cancer diagnosis, will at some point in their journey have seen a traditional healer or a faith healer. So working with those people to actually say, when you see X, refer to Y. So trying to kind of build that things and actually training those community people to take the lead on that. And it really does help to at least that early stage of referral.
One of the things that was not discussed as a hurdle, but which I came across when I was talking to survivors, a few of whom are in this room, was that, and perhaps this is no longer the case in high-income countries, but I wonder if it is in low-income countries, that the parents noticed something wrong with their children's eye, and it was the doctors who they went to see who said, no, it's fine, it's nothing. And I wonder if that if there's a parallel situation, if that's still going on in the United States, if that's happening around the world.
That's very much so still going on in the United States and around the world. A lot of, again, because it's difficult for them to see and to detect the leukocoria, where during low light at bath time, a parent will detect it. It's just not seen and not recognized. Unfortunately, we've had cases where even when it is recognized, there's not a link made, like in the United States, in California, with a huge RB center, the link isn't made that this is retinoblastoma and care is further delayed. Mm-hmm. The other thing to state in terms of referrals is that if you refer to Children's Hospital Los Angeles, top 5 children's hospital, great place, and you say, I think this child has retinoblastoma, it's gonna come to me immediately and we're gonna get your kid in right away.
Right.
If you refer for failed vision screening, I mean, we might not see that kid for a year.
So, okay, going back to this very big question, given the World Health Organization's goal of 60% survival rate by 2030, which, is actually not that far from now, and all of those hurdles, can you just each talk a little bit about what your organizations respectively are doing to try to meet that goal, what you've found to be the most successful angle to work on, and maybe what's the biggest hurdle? We could just go down the line. Jesse, if you want to start.
Sure. So, I'm representing We See Hope and One RB World here, and that is a unique group, right? Children with failed vision screen or parents of children with failed vision screen do not come to One RB World or do not seek it out, but for a diagnosis of retinoblastoma, they do, and it's something that I give to all of my parents, again, even in California and even in the United States. I think they do a really good job of level setting the playing field, because some parents are able to process the medical information at a different level than others. I think they are very committed to taking away the stigma around enucleation and not describing it as a disfiguring surgery, but rather a life-saving procedure in many places. And hearing that, and hearing from experts, yes, even if you were in my care and not in the middle of some other country, enucleation would be an absolutely reasonable procedure to save your child's life, that helps so much. Because we have gotten so good at treatment of retinoblastoma, which, yay, right? Like, I applaud this. The focus has moved in so many cases from saving the child's life to saving their eye and vision. Mm-hmm. And I'm an eye doctor, I'm an eye surgeon. Like, I love to see the retina. I love saving a child's eye. I heard not that long ago, well, you take an eye out of a kid, you can't put the eye back in. Well, you know what you really can't do? You can't take a kid out of a coffin. Okay? So we have to prioritize that. And there's such a rush to run to whatever eye-saving treatment there is and run from your place and get on plane flights and go to this place and go to that place. And it forgets the fact that we have a kid with cancer and we have to save their life. And we have to do any treatment that we do for their eyes safely, remembering that the number one is to save their life.
I think that's a really good phrase. No, you're quite right. So,
I won't put it on a business card.
Yeah, it's not super positive, but it's really
yeah.
true. So I think at World Child Cancer, there's a couple of things that we're doing. So one of the things that Guillermo talked about in his presentation was the challenge of treatment abandonment. I think that one of the things that we really focus on in our organization is funding psychosocial support, which provides that care and support, as well as financial, and emotional, not just for the children, but for the parents and for the healthcare staff as well. And it's one of the biggest things that we do, which actually helps to overcome treatment abandonment, because for a lot of the families that I meet when I go to the countries that we support, getting and the cost of getting into treatment and then staying in treatment, and the pressure from families to come back, and to not pay for that next round of treatment, is huge. Mm-hmm. And you're sometimes having to choose between treatment for one child or food for another in extreme cases. It's really significant. These are not, you don't make a choice about your child's treatment flippantly. These are really significant decisions they're making. So that psychosocial support is a really big element of that, as well as the actual kind of the care element during the treatment. The other thing that we're doing, so we also invest quite a lot in early warning signs and symptoms, to trying to kind of raise that awareness in communities, to try and kind of, because as you say, it's the parents who are often the first people who spot those things and who will then ask someone they trust what they should do next. Mm-hmm. You asked about challenges. I think that I mean, I only joined World Child Cancer in January. I've been trying to look at the data for what we've done and how impactful early warning signs and symptoms is, not just in our own organization, but elsewhere around the world. I would still question how effective, there's not great data on how much is that actually saving lives. Are we getting children to diagnosis early enough so that it's treatable? It's not terminal, and you're not looking at end of life care. So one of the things that we'll be doing between now and 2030, one of the things that as we're writing our strategy for this period, is to kind of work out who's doing what in the field of early warning signs and symptoms. Can we get data on this? Can we measure so that we're consistently looking at those measurements and saying, is it not just getting people to hospital, but is it getting to hospital early enough that we're actually seeing better outcomes for children? So it's one of the things that we're hopefully going to have in the new strategy.
Michael?
Yeah, thank you very much for the opportunity to join the panel. As I say, I'm the co-director of the ARIA Adapted Regimen Implementation Program, and I'll explain that in a little moment. I was represented at PSYOP on the very first meeting of the WHO GICC in 2018. It now seems 2030 seems a lot closer than what it was in 2018. When we were selecting the 6 index cancers, we were aware of a number of things. Firstly, that the global burden of childhood cancer, we estimate around 475,000 children per year develop cancer. What we know is that less than 50% of those ever see a pediatric oncologist. Most of those children live in countries where there are very few pediatric oncologists. They are managed by general pediatricians or family physicians. The other point in selecting the index cancers is they're curable, but they also overlap. If you have the skills to treat a Wilms tumor, as a bystander effect, you'll have develop the skills to treat other abdominal tumors. If you can treat an eye tumor, you can treat other tumors. If you can treat low-grade glioma, then in due course you may be able to treat other brain tumors. Where we work in Papua New Guinea, and I've been involved with Papua New Guinea for over 10 years, retinoblastoma is the most common diagnosis of a swollen eye, but it's also the most common misdiagnosis of a swollen eye. We see trauma, infection, other malignancies, Burkitt lymphoma, rhabdomyosarcoma, myeloid sarcoma, and low-grade glioma. So these are all other diagnoses. So the issue is about education of healthcare practitioners who are not specialists in either eye care. They're not pediatric oncologists. They're not ophthalmological oncologists. So this brings us back to where ARIA is. So ARIA is a collaboration between St. Jude, CCI, the International Children's Cancer Organization, IPSO, which is the International Pediatric Oncology Surgical Society, PROS, which is the Radiation Oncology Society. And what we've done over the last 5 years is develop a collaboration to look at adapting treatment into the safest, most effective and affordable treatments that improve accessibility. So we're currently working on 14 diseases, some 60 supportive care topics, surgery, radiotherapy, nursing, etc., as a guideline collaboration. And that's now I think we have something like 575 healthcare professionals involved in the project. So sponsored and supported by St. Jude as one of their programs. So it's a very large program.
Can I ask a question about
that?
Yeah.
Absolutely. Let's make it a conversation.
Does that program develop different, regionally appropriate differential diagnosis? Because obviously that diagnosis in North Africa might be completely different to Pakistan, Bangladesh. So is it working on that as well?
Did I set you up to ask that question? Well, the answer is we know that different malignancies will present in different contexts in different ways. One of the things that I teach our registrars and our fellows is, unfortunately, very often we say, well, how long has the disease been there to assist in making a diagnosis? But most parents are terribly embarrassed when they've got a child with a major problem, and we'll always usually say it's been there 1 to 3 months, when it may have been there 6 months, 12 months, etc., because it's just embarrassing and it's a loss of face. So there are those sorts of aspects in being able to say, let's make an earlier diagnosis, but can you really, is that an accurate way of doing things? One of the issues we have is should we adopt treatments that have been developed in high-income countries and just use those? Or should we adapt treatments that use lower resources? And that's actually an ethical dilemma. But what parents want is they want something that's safe, that's trusted, that's based on the best evidence, but is adapted to their context. Because if you use a very intense protocol out of context, your actually mortality from treatment-related death goes up.
I was curious if, related to the abandonment of treatment, I don't know if this falls under the umbrella, but especially in low-income countries and for in places where there isn't a lot of access to medical care in rural places. One of the things that became clear is that once you have enucleation, you then have a prosthetic eye, which does require upkeep and care and proximity to an ocularist. And if that is part of the sort of reluctance on the part of parents of like, I'm not going to be able to kind of maintain this going forward. And so they just resort to short-term thinking. I don't know if that's a factor at all.
You go for it.
Yeah. I mean, I think stigma at any stage of any cancer treatment. I think one of the kind of early warning signs programs that our Dutch member runs is called "It's a Disease, Not a Curse." So it sounds really simple, but actually, there's a mindset of, I mean, when I used to work for Sightsavers, I met a girl, I think it was in North India, who was blind, and she had never left the family home. She was 7 years old, and she'd never left the family home because her parents were embarrassed about the fact they had a blind child. So we'd provided support for her to get out, and then suddenly she was actually had friends and was living a normal life. But it's a challenge. It is, and it's not something that you're going to overcome quickly. But as part of what we do and the kind of early warning sign stuff is to try to educate people, and that in messages like "it's a disease, not a cure," is really important to that, because it just helps to start breaking down some of those barriers of stigma.
Just a comment about abandonment. I think it's time we abandon the use of the term abandonment. It's very pejorative. Yeah. It implies that parents made a decision to deny their child the opportunity for treatment, when we know there are many cultural, religious, social, economic factors that impair a family's ability to stay in a treatment centre and get treatment. When we first started working in Fiji, one of the cleverest nurses who I worked with there, when we were running a clinic, when the mother came in with the child, the nurse shook the mother's hand, which I thought was a little bit unusual. But what I didn't realise is that she was slipping her a $20 note, which allowed her to buy food for her family, a bus fare on the way home. And if you want to improve the survival of children with cancer, the most important person in your unit that you employ next is a social worker who can provide support for the family, support so that the children back home aren't denied food, and that she's got a bus fare to get home. So there are very simple, practical measures that can decrease abandonment that have nothing to do with treatment.
How hard, I mean, that's another hurdle then, right? Especially in low-income countries where there's difficult access to medical care, but then also to social workers, to that whole kind of network. Guillermo, are there other cultural sort of challenges that are impeding progress?
Yeah, absolutely, and they differ all over the world. They are not the same. So sometimes we discussed one strategy for one setting that could work to prevent abandonment, but that doesn't necessarily mean that that exact approach would work in another setting with different realities. Sometimes there are cultural things, sometimes are more economical things, sometimes are even geographical barriers in many countries. And we are also even studying the impact of global warming, for example, in the changes that are occurring in the world that are making the families less prone to take the child for treatment. So unfortunately, we also learned that there is no one-size-fits-all for tackling abandonment. For example, a group in sub-Saharan Africa is subsidizing the families for transportation and food, for example. But that probably would not be the necessary thing to do in smaller countries in Central America, for example, where abandonment would be related to other factors. So we need to study for a multidimensional point of view in each of the cultures, which are the cultural determinants for abandonment, which is not a very nice word to say.
You know, and I've been working on it over here since the only expertise I bring is words. So I was thinking treatment continuity, and you can talk about successful treatment continuity.
Exactly.
Okay, so
It's
my suggestion.
And we've been wrestling with the appropriate term. Treatment non-completion is another way of saying. So you define it as what are the events that led to treatment not being completed or treatment not being initiated?
How do you define that, treatment non-completion? I'm using your term now. I've picked it up. I mean, what does that mean? Does that mean between diagnosis and enucleation, or is it where are we talking about it? Because again, you could talk about it even further down the road or earlier, I assume.
I think it's very important to differentiate when this problem occurs. Sometimes in retinoblastoma, it can occur that you make the diagnosis, you say that to the family that the enucleation is necessary, and then the family disappears and comes back 3-4 months later with a huge orbital mass. That is something that occurs. It's probably the most common cause of what we call abandonment, because it's a general term for other tumors as well. But it may occur also in some settings where conservative treatment is available. So you could try to save the eye, you give treatment to save the vision, and then usually when the treatment in the second eye fails, so you already enucleated one eye and it fails in the second eye, so that will result in blindness. This is the time when many families also opt out of treatment and then also come back with metastatic disease of extraocular disease, which is really even more painful because you were thinking that you would able to save the vision, and the child ends up paying with his or her life. So, and there is also abandonment of treatment when you, for example, enucleate the eye and then you need chemotherapy to try to reduce the chance of extraocular disease, and some families don't accept that treatment, and then the disease recurs. So in general, this will be like the 3 more common scenarios in retinoblastoma, being the first one the most typical.
Sorry, I also think, and I'm going to preface this statement by realizing that it comes from a place of immense privilege, thanks to some people in this room, but I think we as a medical community should also start to talk about ways to make enucleation better. Like, we sort of approach it like, well, I mean, it's life-saving, so like, you know, it is what it is. They have to do it. We're going to push them to do it. And I get that, but Dr. Galley visited me about a year ago, and I think we had done an enucleation that day, and she said, oh, we don't use clear conformers anymore. And when Kat talked about her daughter and getting some feedback at a birthday party with a clear conformer, it reminded me that we changed our practice. So instead of using clear conformers where you see the bloody healing tissue behind, we now, because of the Haddads, they donate an array of pre-made prostheses that are not perfect, but they look pretty darn good, and I'm so glad that you shared this idea with me. And even with our parents, when I show them a picture of a child that was enucleated that has one of these temporary prostheses in, they're like, oh, that's what they look like after? Oh, okay. It's totally different. And I don't even know how to study this in a way to make it publishable, but I can tell you that there's a palpable difference with my families pre and post enucleation. Dr. Shaw is shaking her head because I think she sees it as well. It's funny, now they're like, oh, I have a little bit of ptosis. And you're like, no. You don't know what this looked like before, but it's a huge difference to take off the patch and not see what they view as a hole, but rather to see an eye. Huge difference.
Did you want to add something?
I was just going to comment one other thing that we don't appreciate enough. There's another form of abandonment, and that's health service abandonment. That's the health services failing families. Governments not with active policies, governments without policies and child cancer protection plans, governments and health services that don't buy the drugs in a timely way that are needed. So there is a health service abandonment.
So this is another kind of big picture question, but one thing that came across even in very populous countries like Nigeria, which was discussed this morning, the number of actual cases is small. So you have the kind of the blessing and curse of a very rare condition. And Anthony Fauci wrote a piece for the New York Times recently about how he had West Nile virus and is worse than anything he'd had in his many years as a public health professional. And he said, but there's really very little hope of anything being developed drug-wise for this because the numbers are still so small, it's just not profitable. So whether you're in a country like the United States, where medicine is often, about return on investment and profitability, or you're in a country with not great resources for its healthcare system, and it just comes down to where do we allocate the funds. How significant a hurdle to getting to these WHO figures is just the very rareness of the disease, and maybe even in comparison with some of those other cancers that are on that list?
Well, we have a great advantage over that rarity is because retinoblastoma is a rare tumor, but the retinoblastoma pathway is very common in many tumors, including adult tumors. So there's a lot of work being done to target the retinoblastoma pathway. In fact, I'm involved in one of them in Barcelona. We have a genetically modified virus that targets a cell that has the retinoblastoma pathway altered. So, but the group that developed the virus did that because of pancreatic cancer, because they was looking for a treatment of pancreatic cancer. And then we say, well, but it is targeting the retinoblastoma pathway, it should work for retinoblastoma. And we have just completed the phase 1 study, and we had a 30% response rate in eyes that were ready for enucleation. So we can find to catch the interest of the industry, of the developers of new treatments by having at least a very popular pathway, probably.
Perhaps I could just follow on from that is in the ARIA collaboration, we have sought and got engagement with nearly every cooperative, collaborative group for childhood cancer with representation on our global representative panels. However, we've put it to many of the leading high-income cooperative clinical trial groups about do they feel there's an obligation to support the development of guidelines that are used in other settings. And actually, we've had a lot of pushback. When I've said and given, I must have given, I don't know how many presentations, and remind that the global interest group in disease X, that 90% of the children with disease X will be living in a low and middle income country. Your obligation as the global disease X experts is to start developing geographically appropriate clinical trials. And this has actually been a really difficult challenge. For instance, and I'm not going to name, well, the Children's Oncology Group, for instance, is a fantastic group that I'm a member of, but their mandate from the NIH is to produce leading research that is the next generation of cure, not curing with the curable tools we've already got.
Right.
So it's quite an ethical dilemma.
Yeah.
I think that, for better or worse, healthcare, the availability of treatments is always about profit, whichever country you're in. I mean, one of the reasons that the treatments are not available in low to middle income countries is just because there's not enough money in it to
Right.
make it viable, which is why you have, Clinton Health Access Initiative and other, you obviously have the global platform and Atom and all these other different sort of schemes, which are fantastic, which I think will make a massive difference to the availability of treatments. But I think that there's still going to be a barrier, particularly for retinoblastoma, in that there is the availability of radiotherapy, laser, treatment, all these kind of things, which actually, in terms of actually having the very best possible outcomes, are essential. And if you look at a lot of the countries we're working in, the availability of that technology is effectively zero for most people. You look at a country, I think in Nigeria, I was just talking to someone at UICC, I think in Nigeria there are, 6 working radiotherapy machines in the whole country, 200 million people, and that's just, it's no good, Most of the countries will not have a laser treatment, so it's just,
Right.
it's not just the treatment, it's they will not have the ophthalmologist, they won't have pediatric ophthalmologists, etc. So one of the things that we're doing is to try to train the kind of the skills to, so that when we can get those technologies in there and the treatments in there, that there's actually the trained professionals who are actually able to manage it, and then you've got to worry about maintenance, all that kind of stuff as well.
Did you want to add anything? Okay, well, I mean, one of the challenges that I've heard from pediatricians and pediatric specialists here in this country, and Jesse, you can back this up or maybe tell me I'm wrong, is that we don't have as many pediatricians as we need. It's not as glamorous a specialty as, being a cardiothoracic surgeon, and it's not as lucrative, but especially we don't have enough pediatric specialists, so that, and the number has been sort of going down and very hard to attract people to this field. So I'm curious if that is a global phenomenon, if that is a factor in addressing a pediatric cancer like this, and what, if anything, could be done to change that?
Yeah, unfortunately, it's a global phenomenon. I usually give a talk saying this is the best time in my life to be a pediatric oncologist, because these things are happening now. You could see now that in very short, limited amount of time, you will see doubling the survival of many tumors in the whole world.
Yeah.
So this is the best time for a specialty, but still, it's a big issue. Very few people choose pediatrics. Very few people choose to be a pediatric oncologist, yeah, unfortunately.
And just an anecdote, I've worked in a number of settings around Southeast Asia, and the first time I visited Nepal, we did ward rounds in Nepal, and we were sitting there chatting and talking about treatments and things, and then they were looking at their watches, and it was after 2 p.m. And I just kept on chatting. And then someone tapped me on the shoulder to say that actually the pediatric oncologists had to leave because they have to go and do their private clinic in general pediatrics, which is really quite common in many parts of the world, that the hospitals pay for pediatric oncologists in the hospital is very low. The incentive to be a specialist pediatric oncologist is very low because it's a full-time academic specialty. Mm-hmm. And most parts of the world, the pediatric oncologists have to work either a morning clinic or an afternoon clinic in private practice to pay their
That's
rent
a whole
or pay their
other
mortgage.
obstacle in these countries.
And so the incentive for young people to train in pediatric oncology, there's no private practice.
Mm-hmm.
And you have to remember, as I think with anything like this, you have to remember it's somebody's career. They spend a lot of money training to become a specialist in whatever area they're going to be a specialist in. It has to be viable financially for them as an individual. And I think there's, so when you've got low numbers, low prestige, low pay, and also if you're looking at actually the majority of the children you're going to treat are going to die because, because they're not getting to treatment early enough. There's not a huge incentive, so it's part of, so what we're trying to do, we're obviously trying to train pediatric oncologists and pediatric oncology nurses, etc., but you have to kind of lay out what the career path is and why somebody might go into it. You have to try to make sure that there's a system there to support them, and they can see that by being part of that, they're going to improve that situation. But it's a hard sell in comparison to other better paid, more prestigious things where somebody's knee is perfect at the end of it,
Right.
So.
I mean, I would think that this is the delay between diagnosis or the first visit and treatment and diagnosis is not as good as it could be even in developed countries, because in countries like Canada and the UK, there's often long wait lists to see specialists for other different reasons than there are in the US, which is, maybe you can talk about what the situation is like in the US.
Yeah. I mean, to be quite honest, insurance plays a huge role in the US,
Right.
whether or not we want to admit that. I'll admit it. And so, a child with a PPO often will get in faster than a child with an HMO or a child that's on, in California, Medi-Cal or whatever government insurance. That makes a big difference in terms of referral patterns. Pediatric ophthalmologists, we also have a shortage of those. Very similar reason. It's a very long training. The reimbursement is quite low, and the cuts for cases are very low. So, a retina person and a pediatric ophthalmologist will train for really about the same amount of time, and yet the retina specialist has double or triple the ability to generate a salary than a pediatric ophthalmologist. And so that puts everyone in a really difficult situation. And I don't know if fewer people are going into RB. I think there are fewer pediatric ophthalmologists going into RB for sure. It tends to be people who are also interested in retina. And I think honestly it's because they have a little more flexibility and they can take a day doing RB where they don't need to make as much money because they are able to cover their expenses the other days of the week.
I want to allow time for questions from the audience because this is such an experienced and incredible panel. But before I do that, Marissa actually suggested I ask this question, and I assume it's because I'm part of the media, which is what role does the media play in shedding light on pediatric oncology and projects like the WHO initiative to the public? And I might add to that also social media, which maybe will bring in people here in the audience too, because everyone is essentially the media at this point. We're so fragmented.
That's true.
I think it's a great topic. In fact, I came 3 weeks ago from Brazil, and Brazil was probably the first country that started actions in the community to try to achieve early diagnosis of retinoblastoma, like 25 years ago. They did this. You know the Corcovado, right? That Christ that is in a hill in Rio de Janeiro. They just built. They just light the eyes with the leukocoria of the Christ there, and interestingly, like the most famous presenter in Brazil in the television had a child with retinoblastoma.
Oh.
So the impact that person could have in the dissemination of retinoblastoma by just being there in Rio de Janeiro, in the Corcovado, like doing these kind of things are really helpful. And they put at the same time, you saw the buses in Rio with the picture of leukocoria and the picture of that person, which everybody knew in Brazil. So it was so generous also to participate in this kind of campaign. So that amplifies our voice, which for rare tumors, it's difficult to measure the impact, of course, but still, I think it is very, very helpful to have that presence in the media, and that's the work that advocacy groups really, really do. Yeah.
Yeah, just thinking on that. While we know chemotherapy and surgery saves lives, so does data and so does advocacy. The chemotherapy and surgery is treating the patient. Data and advocacy are the best way of treating the healthcare system. And advocacy, part of that is public awareness, awareness through the media, to advocate for health services to improve the services they provide, health ministries to improve the services, to have dedicated national cancer plans, etc.
I think that one of the things I'd recommend on this front is that there's two things that really sell, stories and success. And I think that, we just got a bunch of photographs back from one of our programs in Malawi of these beautiful smiling children, and they just light up the room when you see these pictures. So we can tell those stories.
Yeah.
And I think but the other part of that story that we've got is that between now and 2030, we've got the best opportunity we have ever had in the field of children's cancer to save lives. And children's cancer is enormously survivable. You know, there's so many negative stories about cancer.
Yeah.
There's lots of nice, interesting stuff coming out about cancer research, but actually saving lives today, what a fantastic story to tell. You know, that right now, and between now and 2030, we can not just save lives now, but we can massively increase the number of lives we're saving. And look at these stories, look at these children who are, you know, because you have to have a pretty cold, empty heart not to, you know, hear the stories of these children whose lives have been saved. To actually, you know, and it makes a huge difference, that sort of sense of positivity, that sense of, yes, we can.
Yeah.
You know, really does make a difference.
Yeah, and I think, you know, there are patients in this room who their retinoblastoma was detected because they saw something on TikTok or Instagram, right? So, you know, follow Know the Glow and tell everyone to know the glow. Post it on your Instagram and your Facebook and tell the moms, it's moms, okay, also dads, but, you know, moms, tell them, like, you see a post about Know the Glow, you share it. And I don't care that your kid doesn't have retinoblastoma, you share it because someone will see your post and will recognize another kid that does.
Yeah, I'll just share one bit from the media side, and I'll talk more about this tomorrow, but this is a story, the story wasn't specifically originally about retinoblastoma, but about pediatric cancer survival that I started working on in 2010. And now you would think, looking at the news, that the media loved negative stories and bad stories and stories to make you yell at walls or tear out your hair or cry. But weirdly, when you work inside the media, there is a reticence about news that is sad. And when I first started working on this story about pediatric cancer survival, I was a freelancer, and I wrote mostly at that time for Time Magazine, the New York Times Magazine, and weirdly, Vogue magazine. I used to say I was on the least glamorous beat at Vogue. I did stories on staph infections and on Lyme disease and like anything, you know, tragic. And the initial response I got when I said I was interested in doing a story about pediatric cancer was, it's too dark. It's too dark. Weirdly, every time I would go to Time first, because I was a contributor there, and they would say it's too dark. When they said that, I'd go to the New York Times Magazine, and then they would say it's too dark. Very often, Vogue would say yes, which I still haven't cracked the code on why that was. But there was a lot of resistance to these kinds of stories, and really had to persuade them this is not a sad story. This is actually a story where there's been tremendous success. I want to end on that little positive note. We can go into negative things with the questions, but I do want to give everyone in the audience a chance to ask this excellent panel of experts questions. The microphone is right there, or if we have questions coming from online.
We have no questions online right now.
Okay, well, we do have some questions here. So.
Thank you, everyone. That was really enlightening. And I kept thinking throughout this, you know, in broad strokes, screening for retinoblastoma is so difficult at a population level, but parents really are the screeners. So in an age where the social media algorithms can sell us, they know where in the supermarket we're standing, and, you know, we're hovering, deciding between yogurt, and they can send us targeted ads. Surely we could use this to our advantage to target every new mom with a video. Is that maybe the way we should go, instead of like a medical solution, something that's more social? I don't know.
So I have a comment on that. Now I'm going to get into trouble. So when I was in college, Facebook started, so I knew some of the Facebook people, and now it's 5 or 6 years ago. Are there lawyers in the room? I should have asked that first. We need you, though. We need some lawyers. So I approached the leadership at Facebook, and at that time they were sort of trying to revamp their image, because this is not hard, right? Like, people upload pictures to Facebook all the time, and AI can detect leukocoria all the time. And the do-gooders at Facebook were super excited, and they took it up to their leadership, and their leadership was like, curing kids of cancer by Facebook? Like, we're in. And then the lawyers were like, y'all have to be nuts. Like, absolutely not. And the absolutely not was, you're going to be sued because you're going to detect leukocoria that's not cancer. You're going to cause anxiety, stress, and fear, and you're going to be sued. You're going to detect leukocoria that is cancer, and the family's not going to have access to care, and that child's going to have a bad outcome, and you're going to be sued. And they gave like 400 more stories of the ways in which we would be sued. So honestly, I mean, Marissa, we need to invite some lawyers next time, maybe, right, to figure out how to craft that back, because as a doctor, I didn't have a great response, aside from like, I'd like to not be sued, thank you.
Yeah. You're speaking like the brilliant ophthalmologist that you are. My idea was not as medical as that, more like seeing a TikTok video. Like that's all parents really need to see, and then be prompted to come see you, who can do the right diagnosis. Why don't we do that?
Yeah.
I don't want to be another negative Nelly on this one, but it's, I think so. So I've been working for like international health organizations like 20 years, and one of the things you see on social media is that there are even as a cancer organization, or previously I worked in multiple sclerosis and eye health, even as those organizations, they have really severe restrictions on what you can or can't say about medical conditions on their platforms, because they don't, it's not just about us getting sued, they don't want to get sued, they just don't want to, so it gets really, you can do it, I think it's a great idea, but I think there's just, but it's just, you'll have to be really clever about how you do it, because of the limitations they put on us and on themselves.
Sandy?
Sandra Staffieri from Melbourne, thank you, that was amazing. I don't have enough words to explain how amazing that whole discussion was. I have a couple of comments. One, media. My interactions with the media is great. It has been a good experience. They love the story. But the awareness message that I want to get across gets lost in the story. The story of the child is sensationalised, which is great, but I need the story to carry the awareness message, and that is around strabismus leukocoria. That was one thing. The other thing is, in a high-income country, and I live where the population is small, we don't have many children. I've had people in the health department tell me 4 children is not enough to get a pamphlet in a parent's health book.
Right.
They've said it to my face. And I'm like, but 1 child is enough, let alone 4. Our children don't die, whereas in a low middle income country, they die. So there's more of an impetus to do something. I went to Papua New Guinea with a batch of posters, thank you Megan from Know the Glow, and they just took them, fabulous, stick them up everywhere. I have not been able to get one single solitary poster on a wall anywhere in my state, in Australia. TikTok, social media, fantastic, but retinoblastoma is more important than incidental awareness, which is what that is. I think we need everything, but it needs to be systematic. It needs to be from the day that baby is born. When I did my PhD, I did a SAT for 3 months in an antenatal clinic doing surveys on parents. And there was one video that they played on rotation for those 3 months, and I'm sure it's still playing, how to bath a baby. They need more videos in their antenatal clinic. We can solve this problem. We really just need to put our head together, and that's for more conversations and more discussions. So thank you.
Yeah, I mean, I wonder if there have been huge public awareness campaigns around shaken baby syndrome, around the importance of reading to your children, which went through pediatricians' offices, if those kinds of things can serve somehow as a model. Yes.
Oh, sorry, can I?
Oh, I'm sorry, I didn't even know there was a microphone over here.
Jumping here. So, do you mind? Thank you, that was wonderful. Paula Dillon, another Aussie accent here. I'm a nurse and midwife. In Australia, a midwife is more of an obstetric nurse, so I've done postgraduate qualifications. And my specialty area is also perinatal loss. There is evidence from Scotland, the UK, Amsterdam, Denmark, about public awareness campaigns and the success of public awareness campaigns of decreased fetal movements in 3rd trimester of pregnancy, and women's awareness of decreased fetal movements and going in for assessment actually saving lives. And they are campaigns talking about saving lives, talking about dead babies, a very sensitive topic. The SIDS campaigns, particularly in Australia, SIDS and Kids, Red Nose, talking about dead babies. And there has been a significant reduction in the incidence of dead babies in the last 20 plus years in Australia because of awareness campaigns. Now, I spoke online about this at RB One World in 2021, and I know I'm preaching to the converted and stuff here, but if there can be campaigns that are out there, public awareness campaigns out there talking about saving babies' lives, talking about dead babies and sleeping them in a certain way, maternal sleep position, being aware of movements, surely we can still have a campaign about having a look in your kid's eyes and taking a photo. I know yes, we could be picking up other stuff, but I'm like with Sandra, it can be done.
Yes.
Thank you very much for the amazing talk. As I told you earlier, I come from Chile, that is a small country in Latin America. And I think what I have realized that we have many different situations in the world. So as you already mentioned, there is no one solution. It depends on the society. For instance, in high-income countries, parents are literate. So simple. They can read the instruction. And they have access to internet, to Google, to read what it is the meaning of the white or red reflex. But when you are living in another country, like my country in Chile, 12% of the population speak English. And even when the population is literate, not so many understand what they read. And that is a challenge. And Chile is a middle-income country, it's not a low income. So I think that in part of the world, the focus could be on the parents, and in another large part of the world should be on the pediatric healthcare personnel. As already Guillermo mentioned, our team has been working for a number of nearly 10 years, developing an app for leukocoria detector. And in terms of technology, we have a product, but the limitation is all the rules and restriction and regulation. And we have been overwhelmed regarding the patient privacy, the AI regulation worldwide, the intellectual property, and sometimes I say, okay, who cares about AI regulations if we are trying to save the life of a child? But you know what? It doesn't matter if you have good intention, if you have your passion, your mission. What we have to do is to fit inside a system, otherwise we cannot be useful as we want. So I invite you for tomorrow afternoon. We will present what we have done and appreciate any comment, feedback you have, because it will be very, very helpful for us. Thank you.
Thank you.
May I add just a small comment to that? I think I fully agree. That is something that we from SIOP are trying to influence in the decision makers, in the general public, because as you mentioned, most pediatric oncology tumors are rare, and they need international collaboration to really change and save lives. And we see that the current laws for privacy are a big limit. And we have to advocate together, because each pediatric cancer is rare, but all the pediatric cancers are not rare. And this is a problem for all the pediatric cancers in in retinoblastoma because of the images, in other tumors that are genetic because you have to share genomic data, but making a cause for the international collaboration is one of the things that SIOP is doing, and need more forces to really change their mind for the data protection, which may be very important for Angelina Jolie, but probably not for the rest of the people with cancer.
We're running a teeny bit over, but I just want to allow these last 3 questions. So go ahead.
Thanks a lot for this panel. I think this brought so many things into the discussion, and I think the importance of awareness, screening, and all of that was quite nicely discussed here. I think my question is more addressed to Guillermo and his comment on the fact that unless white reflex detection actually brings in improved survival, then it won't make it to the screening test category of things. Of course, that's the SIOP perspective, but maybe the red reflex test obviously has other vision purposes that does still hold it as a screening test. I was just wondering, even if we don't have the SIOP cut, can we make at least the ophthalmology cut of still recommending screening, but for vision purposes and maybe incidentally detect a retinoblastoma? That being said, I have done this now for 15 years or more, and I still haven't had one child come in with through a red reflex screening. I've had them come in diagnosed with, let's say, a strabismus that then got a red reflex test done and then came in, but not a well baby screening. So your point is absolutely well taken. I think there is a middle line there, and maybe I'd like us to comment on the priorities of SIOP versus the priorities of ophthalmologists, and how do we reconcile that, and truly I think awareness is somewhere there, because having awareness of the white reflex, we're targeting a lot of mothers and others through social media, but doctors themselves who don't have the awareness. And I've practiced in India, and I've practiced in Canada, and I've also practiced in Australia. And in all 3 countries, there's still the same thing, where the parents are met with that obstruction at some point, where they understand, they've seen the social media ads, they've seen what they can, they've gone to the doctor, but then the doctor has flashed a flashlight into the eye and said, no, this is not retinoblastoma, or this cannot be, I don't see any trouble in the eye. So I think that the awareness part of it, and how do we reconcile that is the question.
That's a great point, Ashwin. And I think please consider that this is, my perspective was as a public health perspective. In this setting, PSA, for example, is not considered a valid screening test right now for prostate cancer. Prostate cancer affects maybe 80–90% of men at a certain age, and it's still not validated. So there are, in order to convince the health authority to carry out a screening to the general population, we need to have that baseline. But that was a perspective from the cancer epidemiology, which is heavily based on adults and heavily based on different biology that we fortunately don't share in retinoblastoma. We are a tumor of growing children that are biologically different. So coming to your reflection is exactly what we as SIOP and St. Jude also decided with the WHO to go with ophthalmologists, because we go for visual health, and we go for that. As you mentioned, it's probably an incidental finding of retinoblastoma when you are screening for other ocular conditions. But that's the way we found, because for the cancer perspective, you need to follow those rules, and there are only 2 mammography and pap smears that are the only screening tests that are validated with such strict guidelines. But it's for the public health perspective, we cannot, it is what they request for targeting a population, a healthy population. So your point is well taken, and that is exactly what the WHO is recommending.
Thank you. That was a big part of my question too, although I did want to say, you know, with the WHO, I know 2030 sounds like it's far away, and yet, you know, it is relatively close, 5 or 6 years, but then you think about how much life has changed in the last 5 or 6 years, and okay, I'm thinking maybe we're not dreaming big enough that we could actually accomplish more. And it does seem amazing to me that in the year 2024, that we can't, with a push of a button, make this information just universally known as we do about moles or about self-checks and things that are of equal importance. Which brings me back, and I love Tiago Leifert, and I'm so happy that his difficult experience with Lua has led to such wonderful awareness, and I'll be excited to see what the ripple effect is of that in your country. But I'm equally, tying back to that other question, was one of the things that I am grateful for with the GLOW is that leukocoria is not only unforgettable, but it can be an indicator of so many other conditions. So again, back to what Ashwin was saying, is it possible, as you were talking about similar pathways, to look at studies that would be more focused on how leukocoria could increase the detection of multiple diseases, although I know getting those baseline incidence rates across the board for pediatric cases is itself its own challenge, since so few are brought forward, especially in LMIC. So it's a cyclical challenge, but if you don't break the cycle somewhere and just dig in and start to move forward, are there any studies like that that are even planned, even if not for the cancer side, but for the ophthalmology side generally?
No, yeah, what I try to say is that it is not just, we cannot just aim to detect early the retinoblastoma. We have also to take care of the rest of the health system, because you need also a place where the children can be diagnosed safely, because some of them may not have retinoblastoma. So we have to have that. We have to have access to treatment, access to diagnosis, and then support for the family to try to complete the treatment. So, and then a good treatment, an effective treatment. All of this is required to cure retinoblastoma. If we, suppose tomorrow comes from Chile the best app to detect leukocoria, and that's all we have, it will be great. Probably we can improve a little bit, but if we don't improve the rest of the health system, and that is the complexity, and that is where SIOP and the WHO and St. Jude are working together to, it's difficult to do, because you have to operate on the whole health system. But that's why retinoblastoma is cured in high-income countries, and it's not cured in low-income countries. And it's not just late diagnosis. Yeah.
I would love to see at some point, either with SIOP or the ISO or otherwise, some sort of early detection forum or an awareness forum or something where you could bring together all of the different principalities that are working from their own countries and sharing what is working, what they are trying, and learning from each other, so we're not all independently creating the wheel. But
well, that is something I mentioned earlier that I really want us to do. I think I'm very, very keen to do something like that. So.
Yeah.
One comment.
We presented a grant last year to the Grand Cancer Challenges. It was £50 million, and we didn't get it.
I was going to say one suggestion from the mainstream media / peanut gallery is that the next generation of parents is on TikTok right now, you know, and they're on Instagram, and there are so many influencers who raise awareness of mental health issues, that if any survivors in the room have any desire to become a social media influencer for good, that's the place to, you know, get to that next generation, I would think. Sorry.
Thank you all so much for being here. You light a passion in me. My daughter was seen by 2 pediatricians that told me that she was perfectly healthy, and 1 month later she was diagnosed with a retinal tumor 50% the size of her retina. So if you could both of those pediatricians I never saw again after that. Well, one we were referred, but anyway, if you can go back to any pediatrician that you know that missed it, educate them. If you can educate other pediatricians, just educate your friends, educate your family, like we're all saying. Can we raise money for a Super Bowl commercial?
Last question.
Not so much a question as a challenge. Ashwin and I heard you say that the place that was decided to go was to the ophthalmology community as the most effective way. So we will undertake to go to the Canadian Ophthalmology Association and to our local and national things, but we would like to challenge all the other ophthalmologists here to do the same for your country. We must have at least 20 countries represented here. And let's keep it on the 1RB World site so that we can say we have taken this to our locals and encourage others to do the same, because I think it's the only way we're going to move it forward with our limited resources with no extra stuff. Just get the information out there and put on the fact that it is on the 2030 guideline and see where they can go, because many of them work in the global health field as well.
All right, well, on that proactive note, we'll end here. Jesse, Luke, Michael, Guillermo, thank you all so much.